the registered dietitian and certified diabetes educator, diabetes care and education specialist. She is the director of diabetes education and programming at Norton Healthcare within the Wendy Novak Diabetes Institute. She leads a team of over 20 education specialists. Michaela is also certified in training for all major insulin pump and CGM technologies. Outside of clinical care, she supports youth with diabetes through her involvement with Camp Hendon, which is a Kentucky-based diabetes camp focused on education, empowerment, connection, and probably most importantly, fun. All right, Michaela, thank you so much.
Thank you, Dr. Thrasher. Like Lauren mentioned, I'm also very passionate about the presentation that I'm going to give today, not just because I'm a dietitian, but because for me, carbohydrates are a fun topic and generally the thing that gets the most hate in social media and has the most bias. So as you're investigating the title, trying to understand where I'm headed with nutrition strategies, maybe a little misleading that I'm pointing out that it's not the carbohydrates, but my goal through our presentation today is to take some of the bias off the carbs, take some of the burden off the carbs, and just help you be more successful when educating your patients about nutrition therapy at the start of their diagnosis to set them up for success. So I want you to start with a clean slate. Wipe away any bias, implicit or otherwise, that you have about carbohydrates, specifically potatoes and bananas, because we're going to talk about those a little bit later in the conversation. And I want you to be open to changing your current practice and moving into best practice. I've personally been in practice for a decade and a half in nutrition and diabetes, and I work with many skilled dietitians. And we've spent a lot of time looking at evidence-based practice. We've helped grow the field of nutrition, which is still relatively young, a baby field in the world of medicine. And so there's a lot of new research and a lot of new practice basics that I want to talk about with you today. I also want to encourage patient-centric therapies. And Sheila did a really great job today of giving us an example of how we can really take the gold standard or that golden practice rule, such as 4 blood glucose checks a day, and celebrate a patient's success when they are able to achieve 1 check a day of glucose checks. Picking a patient-centric approach is really going to help you be more successful in working with your patients and is going to help the patients feel more empowered. And that's really important with nutrition therapy because it is such a personal choice for many, many people. And then finally, I want you to keep in mind that many other factors impact glucose metabolism and management. We've heard from Dr. Watson that there's a lot of environmental factors that can contribute to the development of diabetes. We also know that the person's food choices can have an impact on their glucose control. And so we'll talk about some of those as we get into the talk today as well. So here's our banana concept. We'll talk about this in more detail. But the first thing that we generally teach patients about carbohydrates is that they are either simple or complex. And it's not quite as easy as that. But let's start by looking first at complex carbohydrates. Generally speaking, there's a couple of key features about complex carbs that make them important for patients to understand. This can be as simple as it needs to be if patients are just getting started with learning about nutrition for the management of diabetes. First and foremost, Dr. Watson mentioned this as well earlier today, and it's a topic that I'm incredibly excited about, some of the new research coming, but the gut microbiome. We know, simply put, that carbohydrates digest all the way from mouth to intestines, and the state of the intestines can have a big impact on how those carbohydrates are absorbed or what happens once they get there. And so being really intentional about choosing foods that are going to help build a good gut microbiome can be really helpful. And that second bullet point really speaks to this. Fiber, I'll say it again, fiber, fiber, fiber is one of the most important things that we focus on with nutrition therapy. If there's one thing that I can get a patient to do that I feel is going to help improve their diabetes management, it's eating more fiber. And generally, the foods that are highest in fiber are going to come with a lot of those micronutrients that Lauren touched on, and are going to be really helpful for overall health in the body as well. So we really encourage lots of fiber-rich foods. And then that third bullet point, combining with protein and fat, having a good mixture of macronutrients at meals can also help regulate glucose metabolism as well. And this is true whether a patient's consuming simple or complex carbohydrates. So we really focus on what else the patient is eating when we look at whether or not carbohydrates are going to be helpful for their diet plan. Simple carbohydrates, the couple of bullet points that I think are important to remember about simple carbs is generally they do digest most quickly. This is not always a bad thing, and it's still important to incorporate some of these foods into a patient's diet. We consider these the fast fuels that we use to fuel sports and activity, which is really important for our patients as well. The quicker those carbs can get into the bloodstream, the quicker they can be available for lots of movement and physical activity. And we also know that these are the preferred foods for treating hypoglycemia. And so it's still important to encourage simple carbohydrates in our patients with diabetes. Now, when we look specifically at type 2, we may be recommending that patients limit these a little bit and trying to manipulate how many of them we have in compared to complex carbs. And secondly, because that is true that they're generally less micronutrient rich as well. And then, of course, some foods are a mixture of both complex and simple carbs, and that just adds a little bit of complexity to choosing foods for our patients. The glycemic index is the call out here, not something you need to be addressing with every single one of your patients with diabetes, but understanding this can help you guide your patients' choices. If they are struggling with hyperglycemia after some meals, you can discuss what some of those foods are. So here's why I'll bring up the banana. I hear very often in my practice and in the practice of my team, I can't eat bananas. They raise my blood sugar too quickly or too high. It's really interesting. Banana is one of those carbohydrate sources that have both complex and simple carbohydrates. Through the lifetime of a banana, it's going to change how much of those simple and complex carbs they have available. So the green banana there on the left, picked right from the tree, hasn't gone through its ripening process yet, is a little bit higher in prebiotic fibers and complex starches. As the banana ripens, there's an enzymatic process that happens, and it starts to break those down into more simple sugars, which is what you see on the far banana on the right. Now, if I could see everybody in the audience, I'd poll how many of you are eating your banana on either end of that spectrum, because I think the sweet spot generally is right there in the middle. It's not as important to focus on this when you're choosing a banana specifically, but it is good to know that food is not as simple as just either simple or complex. So really quickly, I want to take you through a very basic, we're not going to get too far in the weeds about this, glucose metabolism. These points that we're going to move through are going to have a basic understanding for our patients on what they're choosing to eat and why it matters. I'll also point out throughout the bullet points here how different medications for type 2 diabetes can impact each of these. And these are often what we use as diabetes specialists to educate a patient on why medications may be still helpful as they're early in their diagnosis and making diet modifications. So first things first, we know that carbohydrates and even a little bit of protein are going to break down into glucose following digestion. Therefore, we also know that eating carbohydrates is going to raise the blood sugar. Next, we know that those glucose molecules from carbohydrates are going to be used by the cells to create ATP, which is our body's energy for fuel. The point that's important here is that we need carbohydrates to make fuel. And avoiding carbohydrates is often one of those biases that either providers or patients have when they're learning to eat for diabetes. Next, we also know that the liver can produce some glucose. Typically, this is happening during periods of fasting or carbohydrate restriction. Most of our patients with type 2 diabetes see this accentuated overnight when they're not eating, and they wake up with high glucose in the morning. So here, nutrient timing can be how we really help influence our patients to reduce those morning sugars. And that's ultimately where nutrition therapy can be a really big contributor to glycemic management. We can help patients reduce fasting blood sugars by having a snack in the evening. We can have them try eating earlier in the day if there's someone who typically skips breakfast. And this is also where metformin kind of shines. Glucose uptake generally requires carrier proteins. We're familiar with the medication, the sodium glucose cotransporters that help with this process. The GI tract and the renal tube are the only two places that this is not required. Glucose is also more available when we have insulin. We know this to be true as well, but it's also important for our patients to understand why insulin is so much more impactful with lowering glucose if they get to a point in their diabetes progression that these other medications are not touching some of the issues that are happening inside their body. And then finally, unused glucose is stored in the cells as glycogen, and this can be available for those periods of fasting, but can also be helpful when we're doing physical activity as well. So as we're thinking about why carbs are important, we have to remember that carbs are a necessary part of life. They're there to fuel the body and to fuel all of the processes that are happening. It's the brain's first choice of fuel. And when carbohydrates are not taken in, generally that's where we start to see some trouble. We heard Lauren talk today about how maybe ketogenic diets are not the best choice for some of our patients. The first way that glucose or carbohydrates are used is from available glucose in the bloodstream. So anytime your body is seeking energy for life, it's going to be looking to the bloodstream first. Once this is depleted, it moves into the muscle and the liver for that stored glycogen. Generally, most people are not depleting their blood glucose, otherwise they'd be having hypoglycemia because the body's pretty good about maintaining normal levels, maybe in the absence of insulin production. But that stored muscle and liver glycogen can be really helpful if a meal is delayed from preventing hypoglycemia. And then third, we do have a small amount produced by the liver in gluconeogenesis. Once these three sources of carbohydrates are depleted, the body switches to ketones. And this is not as devastating in type 2 diabetes as it would be in type 1 diabetes, but generally we're trying to avoid this through nutrition therapy by having carbohydrates readily available throughout the day. So let's talk a little bit about the specific diet that has come from lots of research and lots of studying along the way. So the American Diabetes Association put out one of the first diabetes-centric diets. This was a caloric-based diet. Generally speaking, 50% of the calories were assigned to carbohydrate sources, and the other 50% was divided between fat and protein, depending on cardiovascular health. Fast forward to now, we're moving into more of a carb consistent where we're still using some of those previous ADA diet components, like using carbohydrate servings of 15 grams as a portion size, and then giving someone 1, 2, 3, 4 portions at a meal. The biggest difference here is the protein and fat is a little bit more flexible. We're still focusing on whole food choices here for carbohydrate consistency, but we've learned that making sure that we're not just spending all of our carb choices up front at breakfast or holding them all to dinner actually leads to a better carbohydrate intake throughout the day. So Lauren spoke a little bit about pregnancy and how we have specific carb goals per meals. The carb consistent diet does very similarly with this and helps a patient identify how many carbs to have at breakfast, lunch, and dinner, just to prevent extra hyperglycemia after large meals. Future state, I think we're going to be moving toward more of a carbohydrate tolerance. This is a term that's been used just fairly recently in the world of dietetics and diabetes. And essentially, this is the individualization of carbohydrate intake. We are moving more toward that patient-centric adjustment where we know some patients can tolerate a higher amount of carbohydrate at meals. We're also seeing type 2 develop in people and body habitus that used to be considered more healthy. We have professional cyclists that are doing 20 and 30 miles a ride, equal to about 2 to 3 hours of activity a day that are developing type 2 diabetes, primarily because of the genetic component that Dr. Watson mentioned today. Carbohydrate tolerance still has some of the same hallmarks as the ADA diet and a carb-consistent diet with a reduced carbohydrate intake. There is some good research that shows a very low carbohydrate diet early in diagnosis can help improve insulin resistance. And generally speaking, we're not really talking about less than 100 grams of carbohydrate per day. But more importantly, we want to adopt a meal plan for patients that they can achieve on a regular basis. The more consistent they are with their plan, the more successful they'll be in the long run. So as we evaluate the effectiveness of an ADA diet or of a carb-consistent diet, one thing I like to point out, especially to my patients, is those calorie needs are generally based on an average of a couple of demographics studied across our population. Most of the calorie need calculations were created prior to the 1980s, and some of that science is a little bit dated. We're not looking more currently at the change in our body population, how our BMI has changed over the last 20 to 30 years, the lifestyles of our patients. We have far less people doing more active labor jobs and far more patients doing sedentary jobs. They're working at computers, they're on Zoom all day, every day. And these types of things have really changed how many calories our patients need, and not always for the lesser. Calorie and BMI calculations also don't account for any of those other factors. Here, other may also include the gut microbiome. Lots of research is emerging that's indicating that the gut microbiome has the ability to affect how many calories a person absorbs from their food as well. This may be negligible for some patients, but it's also important to remember that calories are not simply 100 to 200, even though our food labels may indicate so. And so as we look at a patient's stress levels, the change in their physical activity day to day on the type of job that they may have, their genetics, and then of course their socioeconomics, all of those things can impact how many calories they need on a given day. And so having a more flexible plan that doesn't put them in a rigid structure, a lot of times can be more successful for them. So when I'm speaking with providers, a lot of the concern that comes up is if the patient leaves my office and I have not prescribed a carbohydrate amount to them, or I have not given them specifics, they're going to fail. And what I like to encourage here is that most of the time patients are just ready to absorb all of the information that we give them, but getting home often are not able to regurgitate all of that information that we've provided with them. And so starting slow and helping them build on a plan can lead to greater success in the future. I also like to encourage that not giving a specific carbohydrate goal doesn't necessarily mean failure for our patients. So when patients are first starting out, just learn which foods have carbohydrates. And so I've mentioned the perceived danger of not explaining amounts. But generally speaking, someone that's diagnosed with diabetes isn't going to go home and all of a sudden start eating more carbs, unless, of course, they have some of that psychological response of feeling restricted, and then that can happen, but most of the time they're not going to do worse. So if you have patients that already understand which foods have carbohydrates in them, they'll be able to skip to concept 2. But really what we want to start with most of our patients is which food is a carb or versus has carbs. Peanut butter is one of the best examples of this. It does have carbohydrate, but it is primarily fat, a little bit of protein as well. And so we wouldn't consider peanut butter a carbohydrate source. Another example would be the banana or the potato that we spoke of. Very little protein, very little fat, and so we're going to consider that a carbohydrate food. So some foods contain carbs, and some foods are what we would consider a full carb source. This process can take some time for patients if they're not familiar with that micro and macronutrient breakdown of foods. One of my favorite tools is a good "Hey Siri, is this food a carb?" And this can just help get them acquainted with all of the nutrients and things in their foods as they're learning. Concept number 2 is one of the most common ways that we help a patient guide toward a meal plan that's going to really help with their hyperglycemia management, especially with type 2 diabetes. So we talk a lot about the plate method, which is essentially just using the plate as a division of different food groups. This is a little different than the My Plate if you're familiar with the ones that are put out by the Nutrition and Dietetics Academies. But 50% of the plate is generally reserved for vegetables, non-starchy vegetables, 25% for carbohydrate sources, and 25% protein. Most of the time, patients are getting a reduced carbohydrate and a well-balanced meal if they follow this framework. It's very simple to follow, which means it doesn't require gram for gram counting. You don't have to give a specific amount of carbohydrate to your patient for them to be successful with this plan. It does require a little bit more planning and forethought as patients are shopping and going to the grocery store so that they know they have foods that they can fit together to make this plan. But a lot of the common foods that they're eating are going to fit into this style of meal planning. There are some caveats to this concept. First being, what if they are starting on a medication? depending on the medication that they're starting on, insulin being one of those exceptions, we may want to guide them toward a more specific carbohydrate intake. Another example would be a sulfonylurea, where they have the potential for DKA development if they're not eating a significant amount of carbohydrates, significant to them. Or if they have a high A1C, the concern of sending a patient home without specific guidance if their A1C is 10%, 11%, understandably can be a little bit stressful for a caregiver practitioner that's working with someone with diabetes. The question that I'll ask in response to that is, how much responsibility are we giving the food as we send patients away from our offices? Starting a medication does not necessarily mean that they'll need to stay on that medication long term. And so help patients understand that food, medication, and movement all make up a shared responsibility. And they don't have to be perfectly successful on a nutrition plan to manage their diabetes. We have other tools where we can help them be successful. So the plate method, I like to give some graphics here and demonstrate that we have all of the foods that often we hear of are not healthy with diabetes. I see tortillas, rice, potatoes, and pasta on all of these plates. The portion sizes here range anywhere from 30 to probably 60 grams of carbohydrate. All would be reasonable for someone that's newly diagnosed with type 2 diabetes. It would be wonderful if all of our patients could eat as colorful as this with all of the fiber that's presented on these plates. But these are examples of how they can incorporate a lot of the foods that they're still really interested in eating and foods that they want to consume and make this meal plan feel a little bit more sustainable and achievable for them. What I like about the plate method is that it is also accommodating if they are going to be eating out, if they're having social events, or even if someone else is preparing their meals for them. A lot of these foods are very common to the people that we're working with here in Kentucky. Very similar types of planning if you have someone who's eating a Spanish diet, an African diet, an Indian diet. All of those different cultures and cuisines have the ability to fit into this framework, which makes this very easy and approachable for patients. So next I want to talk through a couple of caveats that really trip us up in a lot of ways as we're educating patients. And this is where we really start taking the burden off of carbohydrate for the management of diabetes. First, I want to encourage that you avoid rigidity and unrealistic goals with your patients. The first one I hear very often is, don't eat anything white. And so here I'll ask, what did cauliflower do? What did milk do? Even potatoes. What are these foods doing that makes you feel like they are so detrimental to our patients? Now, I say this with a smile because I also know that a lot of times our patients are eating French fries for lunch. They're having sauteed potatoes for dinner. They're waking up and having a hash brown for breakfast. The quantity and the frequency is really where these foods tend to hit their limit. And so as we're encouraging patients to eat healthfully, we want to look at quantity and frequency more so than the individual foods. All of those foods I mentioned can be eaten in a healthful way. We just want to be encouraging patients to choose foods that look as close to the way they were produced in nature as possible. Next, avoid desserts. This one I take personal offense to for some of my patients because many people are not eating as much dessert as we think they are. Again, it comes down to the frequency and the portion that they're having, but I want to get away from setting rules that are so specific, especially this time of year where desserts become a cultural and social part of life. Doesn't mean they have to avoid them, but there are more successful ways to incorporate dessert with meals. If we think back to the plate method, we could replace the potatoes or the pasta from our meal, having a low-carb meal with meat and veggies, and have the dessert as the carbohydrate source every once in a while, and still have great success with a nutrition plan. Lastly, 30 grams of carbs per meal is a blanket statement. This is really difficult to achieve, especially if you're eating plant-based or heavy, high-fiber foods. 30 grams of oatmeal is a very small serving of oatmeal. If you add any berries or a scoop of peanut butter to that, you're usually exceeding 30 grams pretty quickly. I would much rather patients choose oatmeal with peanut butter and berries on it for breakfast than something that is way more high in fat or way more processed carbohydrate. And so again, I'll go back to carbohydrate tolerance and look at what the patient is currently doing. If your patient is already consuming 130 grams at each meal, which is not unheard of, going to 30 grams per meal can be a drastic change. And this is going to lead to less success for them maintaining that plan long term. Now, I won't say 130 grams is what we're going to recommend for that patient, but finding a reduction that's at least initially comfortable and helping them adopt that to find their individual carbohydrate tolerance. The next caveat is avoid complexity and overcomplication. A lot of times for our patients, they're getting started learning what carbohydrates are. I like to liken this, my grandfather was a pilot, and so I always talk about how he learned how to fly a plane just by getting in a plane with another person and watching and learning. If your provider said you've got 3 months to learn how to fly a plane, many of the clinicians on this call could figure out how to do that. With diabetes, we're asking our patients to do something that could be as complicated to them. They're going to need to look at the resources. They're going to need to do some online searches. They're going to need to read some books, talk with friends and family, and try to figure out how to carb count or how to manage their nutrition plan. So keep that in mind as you're giving your patients recommendations. It doesn't have to be complicated to be successful. We're not asking them to fly a plane. So instead of what color are you eating your banana, the earlier example, let's focus on how many bananas are they eating. So again, I go back to portion, I go back to frequency. If they like the brown bananas that are generally higher in those simple carbohydrates, we're going to figure out how to combine some foods with those bananas to reduce the hyperglycemia effect. We're going to talk about other foods they could rotate into their plan so they're not eating them all day, every day, and help them achieve something that's a little bit more realistic. Another way to phrase this is to address the bucket in the bathtub, not the ocean. If there's a particular food that your patient is just really favoring, we hear this a lot with certain sugary beverages, try to find one swap that you can make with them that's going to make a big difference over time, one bucket of water at a time, versus trying to change everything in that initial visit. The last caveat that I want to address is morality and psychological restriction. When we are approaching patients that have eating disorders or just disordered eating in general, we have to be very cautious of attaching a good versus bad morality to our foods. This can lead to binge eating. It can lead to cyclical dieting. And really what we're doing here is just educating a patient on how this food individually impacts glucose, not whether or not it's something they should or should not be eating. Also talk about whether or not the food has fat. Does it have extra fiber? Does it have micronutrients that are going to help your body be healthier? If you have someone that's really science savvy, you can talk with them about the different chemistry of food. Resistant starch is something that's emerging in research today with diabetes management because it does have a lower glycemic index. This is not for every patient, but it is something interesting if you have somebody that just wants to understand better how different foods can impact their blood sugars. But have conversations with them about what choices they're making and maybe some swaps that they can make from time to time. And then the psychology of food choices and satiety. We know that fat and protein are two of the macronutrients that give the highest satiety, meaning they help our patients feel full and satisfied longer after meals. But we can't forget that carbohydrates also have a psychological satiety effect. And so making sure that our patients are enjoying what they're eating is also going to be helpful in helping them maintain those changes long term. So we'll wrap up with a little summary of the best strategy for our patients. I've already mentioned fiber. Non-sweetened beverages, this is one of the non-negotiables that we do give our patients when we're talking type 2 diabetes. Spend your carbohydrates where you're going to get some nutritional benefit and choose diet or unsweetened beverages for your liquids unless you're treating hypoglycemia. Individualized carbohydrates. We're not as often recommending carbohydrate goals to our patients. We're first getting to know them and what they're taking in and helping them find where their individual tolerance is using glucose checks. Sustainable change. We want our patients to maintain these changes that they're making today, tomorrow, and 10 years from now throughout the life of their diabetes. And then finally, we want our patients to feel empowered. Initially at diagnosis, one of the worst things we can do for our patients is make them feel like diabetes is something they can't manage. We don't want them to feel like the meal plan is something they can't apply. So the more empowered our patients feel, the more successful they will be in the long term. So new way of thinking, carbohydrates fuel the body. They're our body's favorite source of fuel. We want you to eat them. Even better if you can pick rich carbohydrates, fiber rich, micronutrient rich, manifest some richness into your life. And the standard of care becomes carbohydrate tolerance, individualizing carbohydrate goals, and remembering that those needs may be as varied as the different color of hair and eyes that you see on your patients as well. Whether or not they exercise, arguably everybody should be. Whether or not they're stressed, they have inflammation, the gut microbiome, again, I'll mention. Lots of things are going to affect their calorie needs, and we have to be getting away from some of the outdated evidence that a calorie goal is based on a certain BMI. So as we wrap up, take some time when you're working with your patients. I know a lot of you are MDs or DOs that are working with your patients with 30 minutes at a time. Rewrite your elevator pitch to be something that is patient-centric and helps them walk through what they need to do. And so I'll read through this with you today. A good place to start with your patients would be, first things first, start learning which foods have carbohydrates. You can take the next 2 to 3 weeks to do this. Write down each item. You're going to put one column on the left of foods that don't have carbs, and on the right, you'll put things that do have carbs. Each time you eat this food over the next 2 to 3 weeks, mark a tally next to it. The next 2 to 3 weeks, circle every item that looks like you would find it in nature. That includes a baked potato, that includes a banana. And then I want you to start focusing on putting more tally marks next to those circled items. This is going to help increase the amount of fiber the patient is eating. When you've achieved that, then have them start working on the plate method. Build the plate to always include a carbohydrate source, ideally from the circled items, a good source of protein, and an additional source of fiber. For good measure, don't forget to remind them to move their body every single day. And when you come back to see your provider, you can build more on that plan. So hopefully you all feel like you're leaving a little bit more prepared to talk with your patients about nutrition therapy basics. Break it down into small chunks so that they feel like they can achieve this. And good luck as you talk about all the ways that patients are going to eat their favorite carbohydrates in their diabetes plan.
Thank you so much, Michaela. We have a few questions. The first one is, clinician states they had a patient who recently was trained, or they had a patient who was trained to subtract fiber from the total carb amount. Is this still recommended, or was this a holdover from a previous school of thought?
That's a great question. Pretty much the only time that we recommend reducing the fiber is when we're dosing insulin and we have someone whose carbohydrate ratios are really well fine-tuned. Reducing the fiber is something that got popular with the influx of ketogenic diets and low carbohydrate diets. The intention there was so that we still consumed foods that contained fiber. So if you have a high fiber vegetable, for example, you don't have to count all the carbohydrates in your total carb intake when you take away the fiber. Pros and cons on that. I think for the most part with patients, it's over-complicating the plan. So unless you're dosing medication really specifically on the amount of carbohydrate that's going to impact the glucose, just eat more fiber. Make sure you're having those sources of carbohydrates in your diet. A potato is going to have more fiber than a potato chip, and so that automatically makes it a better carbohydrate source.
Yeah. What are your thoughts on intermittent fasting in those living with type 2?
That's a good question. I have my own personal thoughts working with patients. The research says that it is no more or less effective than a low-calorie diet as far as achieving weight loss. When we look at diabetes specifically, the research is a little bit weaker just because it can be more challenging, especially with insulin or the sulfonylureas that I mentioned to reduce intake at certain times. I think for a patient, choosing the plan that's going to be most effective at sticking with it. Generally speaking, we don't want you fasting more than 6 hours during waking hours because we know that the liver can produce glucose between meals, leading to hyperglycemia as well. So I don't generally recommend an intermittent fasting plan just because I find that a balanced meal plan works just as effectively without a lot of those hard and fast rules.
Okay. Would you like to, can you make any comment on non-sugar sweeteners, especially in regards to the gut microbiome?
Yeah. So just a little bit of research coming out about those. It is an artificial product. So generally speaking, we want you to get your micronutrients and macronutrients from foods that are natural, that are um, not chemically created. In the world of diabetes, artificial sweeteners are one of the ways that patients can enjoy foods that they love and enjoy. And so I'm never going to tell a patient that they can't have their Diet Coke, but like all things, not consuming large quantities of these is important. There's no food out there that's safe to consume unlimited quantities of, and that includes something as simple as water. But be cautious of using them, especially if you do exhibit signs and symptoms of intolerance. Some people report migraines, some people report GI upset. And anytime that you're inducing diarrhea or constipation, you're affecting the gut microbiome. So hopefully we see some more research about how those directly impact that as we go.
Perfect. Well, Michaela, thank you so much. At this time, guys, we're going to take a little pause. We're going to take